Hey everyone, this is my oral for the second assessment of ECP, the presentation and defense assessment. So just a quick introduction to the client that I've chosen for this assessment. I was first introduced to him over on my first placement block at Stawell Regional Health, and he was decided to be used in this assessment due to the level of disability that he's currently living with. So he's a 68-year-old male who was referred to the hospital to undertake exercise rehab for complications regarding his recent ischemic stroke, which happened 8 weeks ago before the initial assessment. The stroke affected the patient's left side of his brain, which caused severe disabilities to the entire right side of his body, but his speech was not affected. It was also stated that he easily fatigued both mentally and physically due to the concentration that it took to actually try and maneuver one of his right limbs. The individual was wheelchair bound and relied heavily on his partner for transportation and daily tasks. It was also reported that the patient was suffering from obesity and hypercholesterolemia, and that he had previously undertaken rehab with a physiotherapist within inpatient rehab, and that finished 1 week before this initial assessment actually occurred. At the end of the initial assessment, the client's goals were established. The patient claimed that from rehab with the EP, he would like to increase his level of independence and functional abilities. His goals were then broken down to be more specific, and the patient reported that he'd like to be able to get out of his bed every day and maneuver himself around on his wheelchair without the help of his partner. The patient was very realistic with the durations that these goals may take to achieve, and it was concluded that these tasks would be reviewed for progress every 3 months, and this would be done via subjective reports and objectively via tasks which replicate the goals that he actually wanted to achieve. Ischemic stroke pathophysiology. So an ischemic stroke occurs due to a vascular occlusion occurring within a blood vessel, which is responsible for supplying blood to the brain. The blockage is often in the form of a floating thrombotic vessel caused by damage to the endothelial lining of blood vessels, and in response, excessive plaque buildup occurs. The plaque buildup then separates from the damaged area and circulates the bloodstream until it becomes lodged, causing the vascular occlusion. The lack of blood supply to the brain caused by the thrombosis results in brain cells to undertake a premature death via necrosis. Necrosis can cause neurological issues for sufferers and can often result in permanent disabilities. The epidemiology of a stroke. So in 2009, it was estimated that over 375,000 Australians have had a stroke throughout their lifetime, and this number actually increased with prevalence as age increased as well. It was also suggested that strokes are more prevalent in the male population as age increased and in causing disability within the male population in older age. All this can be statistically seen in Figure 1, Figure 2, and Figure 3. And all these statistics actually suggest that my client was more susceptible to having a stroke. So the pathophysiology of hypercholesterolemia. So hypercholesterolemia can be regarded as the excessive accumulation of low-density lipoproteins and the limited amount of high-density lipoproteins within the bloodstream. Unnecessary levels of cholesterol are introduced within the body via dietary intake, causing the liver to have difficulty filtering cholesterol. With liver filtering issues, the low-density lipoproteins transport excessive cholesterol into the bloodstream, overpowering the high-density lipoproteins' ability to transport the cholesterol back to the liver for digestion, causing elevated cholesterol levels within the bloodstream. So the epidemiology of hypercholesterolemia. It's reported that high cholesterol is more prevalent as individual ages, which can be seen here in Figure 4. This also may suggest that my client was at a high risk of developing high cholesterol before he actually was diagnosed. The pathophysiology of obesity. So obesity is regarded as a process of excessive accumulation of adipose tissue based on an approximation of body fat via the body mass index equation. For an individual to be classed as obese, a BMI value of 30 or greater must be achieved, or a waist circumference in centimeters of 101 or above for males, or 88 or above for females. The epidemiology of obesity. So statistics actually document that obesity is more prevalent within the male gender and as age increases until the 85 and above age bracket, which can be seen here in figure 5. This also may suggest that my client was at a high risk of developing obesity before he was actually diagnosed. After the initial assessment, objective testing was undertaken. We first started off with a heart rate value, which was read on his non-affected arm. This was done to determine a baseline heart rate. In determining a baseline heart rate, it assists in determining if any abnormalities are actually occurring on the day, which can assist in enabling the patient to actually undertake exercise or not, and predicting any future complications. We then did a blood pressure reading, which was also taken on the non-affective arm. Due to the client actually suffering from a stroke, monitoring blood pressure values regularly is beneficial to determine if any abnormalities are actually occurring. This is essential in determining if any future complications might be arising and to determine if the client is able to actually undertake exercise or not. Oxygen saturation level was then undertaken, and this was tested due to individuals who have actually suffered stroke and more susceptible to hypoxia within their affected stroke regions. So it was important in determining a baseline saturation level for the client, as this can gauge if an individual is at a level to initiate or maintain exercise and to see if any complications are actually arising. A grip strength test was then taken. This was undertaken via a dynamometer. This was undertaken to see the grip strength differences in the affected and non-affected upper limbs. This can be used as a baseline measure to show progression to the client and can allow the EP to have an understanding of how the strength is in the upper limbs to assist in exercise prescription. Evidence also suggests that this method is appropriate in measuring grip strength, and when undertaken on the second notch, as this was, it is very effective at measuring maximal grip strength. Due to time constraints, the objective tests shown on this page here were actually undertaken in a follow-up session. We first started off by getting shoulder and elbow range of motion, which was undertaken via the goniometer. This test was undertaken to determine the range of motion on the affected and non-affective joints. These values could be used as a baseline to show progression to the client and can also assist the EP in exercise prescription. It was reported by evidence that the goniometer is actually effective in measuring range of motion in both the elbow and the shoulder joint. We then did a manual muscle test of the lower limb, and due to the client being in a wheelchair, it was chosen that knee extension and flexion would be appropriate in doing so. This can allow evaluation of both the affected and non-affective quadricep and hand strength groups. This will assist in prescription for the EP and progression aspect also for the client. And strength was determined based off the table above from 1 to 5. And this method was also deemed reliable for chronically ill patients, which my client was. We then did 2 tests which orientated around the patient's goals. This involved rolling over on the plinth, which represented the goal of getting out of bed. And then we did another test that involved the patient moving his arm to grab onto the wheelchair, which then represented him for his wheelchair goal. These tests were said to be undertaken in 3 months, as the client claimed that he could not actually undertake these activities on the day. And then progression was monitored via the subjective evaluation and objectively via visual representation. These are the values obtained from the objective tests that I previously spoke about in the other slides. It can be noted that the values achieved on the patient's right side of his body were severely lower than the values achieved on his left side of his body, which can give you a good indication of the level of disability that he's currently trying to live with. These values were then placed under normative data and put into a ranking. So his heart rate was considered normal, his blood pressure was considered normal, his grip strength on his left side was considered good, but on his right side it was considered very poor. The range of motion within his shoulder, so when he was undertaking flexion, actively on his right side was very below average and passively below average. His left side actively was above average and passively was also above average. When we did abduction, his right side actively was very below average and passively was very below average as well. Left actively above average and passively above average. When we undertook internal rotation, right was very below average actively as well. Passively was very below average. And then left actively was above average and passively was above average also. Values obtained in his range of motion within his elbow flexion. So right actively was very below average, passively was also very below average. Left active was just average and passive was above average. When we did the muscle manual test based off that scale, the right quadricep group was average and the hamstring group was average as well on the right side. On the left side, the quadricep group was excellent and the hamstring group was excellent also. His oxygen saturation levels were also considered healthy range and it was considered that exercise could commence. The interpretation of the objective testing based off normative data. So it was areas that considered poor, his grip strength within the client's right side, suggesting that muscle weakness within the client's right wrist or forearm. His right shoulder joint of motion with flexion, internal rotation and abduction, implying that the client has very poor range of motion within his right shoulder joint. His right elbow flexion is limited within the client's right side. Hamstring and quadricep strength within the client's right side was also considered weak, and that all exercise treatment and prescriptions should aim to address these critical areas. So potential barriers associated with this client that might actually cause issues with his care that he receives. So they were broken down both internally and externally. Financially, he might actually have issues with healthcare schemes not providing him any money. And he also might have issues with the long-term payment that is associated with his treatment. His increased fatigue, both physically and mentally, might also be a barrier in causing limitations in dosage that the EP can actually treat the client with due to frequent breaks being needed throughout. Barrier might also be his motivation. Due to the level of disability and the injuries that he's suffered from his stroke, his motivation might actually be dropped, which might cause implications with his effort and his attendance to treatment sessions. If we go into the external factors, him getting into the hydrotherapy pool might be a barrier due to him needing to be hoisted in. Limitations might be associated if the pool does not have a hoist, and if they do have a hoist, 2 health professionals may be needed in assistance to get the client into the pool as he is considered obese. Another barrier might be him manoeuvring around in his wheelchair throughout the gym. If the gym is not wheelchair friendly, it might cause potential issues in him getting to different areas and equipment throughout the gym, which will decrease the quality of his treatment. And transportation also might be a barrier. If his partner is not available, he might not be able to get to and from the treatment session, which might cause issues in him actually attending. These were the references that I used throughout my assignment, and it was undertaken by the JSAMS referencing, as you can see here.